Hello everyone. Today we'll be dealing with an interesting topic called TDM or Therapeutic Drug Monitoring. Before going into TDM, first we need to understand how normally we monitor the effect of a drug, or simply how do we adjust the dose of a drug in clinical setting. Suppose we are trying to treat hypertension in a patient. After giving a drug, we ask the patient to come back after a week. Then we measure the BP again. So if the BP is near to the target BP, then we continue the same dose. But what if the BP is still high? Then it means that drug is effective but is not completely effective. Then we need to increase the dose. So what if the BP is too low? Then we need to reduce the dose. So that is a normal method of adjusting the dose according to desired response. But this is not practical in everywhere and in all situations. And there are situations where we are not able to measure the response to a drug, or it is too dangerous to play with the dose of a drug. Then how can we adjust the dose? We all know that effect of a drug depends on the plasma concentration of the drug. So by finding out the plasma concentration of the drug, we can know the effect of a drug. So this is known as therapeutic drug monitoring. So how do we define therapeutic drug monitoring? Therapeutic drug monitoring is the measurement of drugs and their active metabolites in patients receiving medication for the purpose of optimizing their therapeutic effect while minimizing adverse effect. So by therapeutic drug monitoring, we are aiming to increase the therapeutic effect and thereby reducing the adverse effect of a drug. Now what are the underlying assumptions while doing a TDM? While doing a TDM, we assume that the drug metabolism varies from patient to patient. That means inconsistent pharmacokinetics. And the drug plasma level of a drug is closely related to the drug's therapeutic effect or toxicity than is the dosage. That simply means that the response should be directly proportional to the plasma concentration, or the graph between the response and the plasma concentration should be linear. Now what are the criteria for doing a therapeutic drug monitoring? So the criteria for TDM is, first it should be available, that is test availability. Then there is narrow therapeutic range, or a drug which is not very safe. Compliance of the patient, high pharmacokinetic variability, and therapeutic effect difficult to monitor. So we will see each of them in the next few slides. The first and foremost criteria for TDM is that the test should be available. So a test for the drug and active metabolites must exist in order to perform a therapeutic drug monitoring. So most of the routine chemistry analysis offer immunoassays for the more common drugs, and some drugs require more specialized chromatographic techniques such as gas chromatography or liquid chromatography. So it requires a lot of skill and highly sophisticated instruments. So therapeutic drug monitoring is usually done for drugs having narrow therapeutic range. So what exactly is the therapeutic range? So the therapeutic range describes the minimum concentration required for effective therapy and the maximum concentration above which there is potential for toxicity. So if the therapeutic range is, or the therapeutic window is very large, then the drug is considered to be safer, since a larger dose of drug is required to produce toxicity. So drugs such as aminoglycosides, digoxin, theophylline and lithium have a narrow therapeutic range, and doses slightly above the therapeutic range can also cause toxicity. Another criteria for TDM is compliance. So therapeutic drug monitoring can be considered in patients that do not show an apparent clinical response to a drug despite being on an adequate dosage. So even after giving an adequate dosage, if patient is not showing any clinical signs, clinical response, then we can go in for a therapeutic drug monitoring. And even after measuring the drug concentration, if the measured drug concentration appears consistent with the dosage of the drug, then the patient may be considered as a non-responder to therapy. So even after giving the adequate dosage of the drug, and if the measured concentration appears consistent, then the patient may be considered as a non-responder to therapy. So if the measured concentrations are very low or not detected, then either the patient is non-compliant, that he is not taking the drugs properly, or it is an unusually fast metabolizer. High pharmacokinetic variability is another criteria for therapeutic drug monitoring. High pharmacokinetic variability means same drug producing different pharmacokinetics in different patients. So it can be due to a multitude of factors. It can be due to age, it can be due to gender, physiological states like pregnancy, due to other drugs, that is drug-drug interactions, genetic polymorphism, malabsorption, in case of liver disease, kidney disease, or cardiovascular disease. So these are the usual causes for high pharmacokinetic variability, and those drugs which are having high pharmacokinetic variability are considered ideal for therapeutic drug monitoring. Therapeutic effect difficult to monitor, that is another criteria for therapeutic drug monitoring. So when we are not able to see clear physiological or clinical response, then we can go in for a TDM. So this is especially helpful in those cases where we are trying to treat prophylactically, that is in case of anticonvulsants, antiarrhythmics, antidepressants, anti-asthmatics, then TDM may be justified. So the decision to increase or decrease the dose is mostly efficiently made on the basis of the serum concentration. So according to the serum concentration that we get by doing a TDM, we can either increase or decrease the dosage for the patient. Now, what are the major indications of therapeutic drug monitoring? Like we discussed before, it can be done for those drugs which are having low therapeutic index, that is the margin of safety is very less, and even if we increase the dose slightly, it can lead to toxicity. When there is poorly defined clinical endpoint, when there is non-compliance, when patient is not complying with the prescription, therapeutic failure, and major organ failure, as in case of liver damage, kidney failure, and in case of cardiovascular diseases, and prevention of adverse drug effects. So if you want to prevent adverse drug effects, especially in those cases where the therapeutic index is very small or narrow, then we can always go in for therapeutic drug monitoring. So these are the major indications of TDM. Now there are conditions where TDM is absolutely unnecessary. So these are when dosage need not be individualized, and when the pharmacological effects can be clinically seen easily, and those drugs which are having wide therapeutic range, as in case of beta blockers and calcium channel blockers, where we can increase or decrease the dosage and does not produce much toxicity. So as we all know, the TDM process is a multidisciplinary function. We need to have a collaboration between scientists, clinicians, nurses, and pharmacists. So this is known as the TDM team. The whole TDM process consists of, first, the decision to request a drug level. Then there is a sample, type of the sample and timing of the sample, the request. So what all the request should contain. Then there is the lab measurements, different methods of lab measurements, communication of results by the lab, clinical interpretation, and therapeutic management. So this is the main procedure of therapeutic drug monitoring. So the first step of the TDM process is decision to request a drug level. So when do you request for a drug level? When you suspect toxicity, and when there is lack of response to treatment, to assess the compliance of the patient, to assess therapy following change in regimen, potential drug interaction in case of co-medication. So these are the reasons for request of a drug level. So once we have decided to monitor the concentration of the therapeutic drug, it is important that a biological sample has to be collected, which will provide a clinically meaningful measurement. So two things are important. One is the sample type, second is the timing of the sample. Now coming to the sample type, either serum or plasma samples are usually collected for therapeutic drug monitoring. We should avoid serum separator tubes, as lipophilic drugs can dissolve in the gel barrier. So it is always better to use either serum or plasma, and we need to avoid serum separator tubes. An important part of therapeutic drug monitoring is the timing of the blood collection. When a drug is administered, the blood concentration increases until it reaches a peak, and then the concentration begins to fall. The lowest concentration, that is the trough, is usually seen just before the next dose, and blood samples should be collected once the drug concentration have attained steady state, that is at least 5 half-lives of the current dosage regimen. Levels approximating steady state may be reached earlier if a loading dose has been given. For drugs with longer half-life, the difference between steady state and trough concentration is very little, and for drugs with a short half-life, the difference between the peak and the trough concentration can be significant, and both are usually measured. For example, aminoglycosides. So drugs that are given intravenously require time to redistribute into the different body compartments, and if toxicity is suspected, then concentration should be monitored as soon as possible. So examples are lithium. 12-hour sample gives the most precise guide to dosage adjustment, and digoxin, the measurement must be made at least 6 hours after a dose to avoid inappropriate high levels, as digoxin requires 6 hours for redistribution to occur. And the example is carbamazepine. Its half-life may be as long as 48 hours following a single dose. So, the request for drug assay should contain the following details. So, and should be effectively communicated to members of the TDM team. So, the most important factors are time of the sample taken, the dosage regimen, patient demographics, co-medication, whether patient is on any other medication, indication for monitoring, that is reasons for requesting for a drug assay, pharmacokinetics and therapeutic range of the drugs. So, these are the details that should be present in a drug assay request. Ideally, a good quality drug assay should be performed within a clinically useful time frame. When the results are obtained from a large chemical pathology lab staffed by highly skilled scientists and equipped with state-of-the-art automated analyzers, clinicians assume that the result obtained will be accurate. Now, what are the different methods or different analytical methods that we commonly use to do a TDM? It can be spectrophotometry and fluorimetry, thin layer chromatography, HPLC, GLC, radioimmunoassay, enzyme immunoassay, and fluorescent polarization immunoassay. So, what are the criteria for an ideal method? An ideal method should be able to distinguish between compounds of similar structure. It should be able to detect even small amounts of the drug or its active metabolite, and it should be simple enough to use as a routine assay, and it should be unaffected by other drugs administered simultaneously. So, these are the criteria for an ideal method. Communication of results by the laboratory. The laboratory should ensure that the drug concentration is available for clinical interpretation as soon as possible after it has been verified by a senior most staff. It should also identify clearly the analytical technique used if there are significant clinical implications. The drug concentration measured are reported in either mass or molar units, and the drug assay results should also clearly state the therapeutic concentration range for the drug assay. So, these are the things to be borne in mind when you are communicating the results by the laboratory. Now, coming to clinical interpretation. Clinical interpretation, if done properly, can add value to the TDM service. The concentration measured must always be interpreted in light of the clinical response, the demographics of the patient, the clinical status of the individual patient, the dosage regimen used, the indication for therapeutic drug monitoring, and the pharmacokinetic characteristic of the drug. So, therapeutic ranges will be available but should be used only as a guide, and there are many factors which alter the effect of a drug concentration at the site of action. For example, serum concentration of digoxin, that is therapeutic for most patients, may be excessive for a patient with hypokalemia. Furthermore, if you are adding any other drug which can be synergistic or antagonistic, so then the dose should be adjusted accordingly. Last is the therapeutic management. A clinician who is caring for the patient will definitely modify a drug dosage regimen in light of all the available information. Physicians usually accept and rely on recommendations of the TDM team for dosage adjustment and seek further advice. Now, coming to the drugs fulfilling TDM criteria. Like we discussed before, TDM is not going to be beneficial for a lot of drugs. But there are a handful of drugs in which TDM can be extremely beneficial. So in cardiovascular system, it can be amiodarone, digoxin, digitoxin, disopyramide, lignocaine, procainamide, propranolol and quinidine. Now coming to antibiotics, gentamicin, amikacin, tobramycin will be benefited. Antidepressants like tricyclic antidepressants, mood stabilizers like lithium, anti-epileptic drugs like phenytoin, phenobarbital, benzodiazepines, carbamazepine, valproic acid and ethosuximide, and bronchodilators like theophylline. Cancer chemotherapy, that is methotrexate, and immunosuppressors, that is cyclosporin. So these are the drugs which will benefit from a TDM. Now coming to the functions of TDM service, there are basically three functions. One is in clinical practice, second is in education, and third is in research and development. In clinical practice, we can optimize the individual dosage regimens and minimize the adverse effects. And additionally, TDM can help to identify problems with medication compliance among non-compliant patient cases. Now coming to education, the basic principles of TDM should be included in the initial training of doctors, pharmacists and even nurses. And in research and development, TDM professionals should target and investigate areas where TDM could improve drug therapy. So these are the main functions of TDM service. Coming to the limitations of therapeutic drug monitoring, only limited drugs are amenable to therapeutic drug monitoring, and there is variability in reporting from labs to labs, and there is only limited access in rural settings. So all these require a lot of sophisticated instruments, and we need skilled professionals for doing therapeutic drug monitoring. So one thing is it's very expensive, second thing is it's not available everywhere. So there is limited access in rural setting, and target ranges are not described for most of the drugs. So these are the main limitations of therapeutic drug monitoring. Now coming to therapeutic drug monitoring in India. Therapeutic drug monitoring was introduced in India in the mid and the late 1980s, and in the past few decades it has seen a lot of growth. The TDM service in our country is broadly divided into two types. In large teaching hospitals where the service is available through departments of clinical pharmacology, and in the private sector where drug estimations are done by clinical biochemistry departments with minimal interpretation. Now coming to the conclusion of our topic, TDM can be useful for establishing initial dosing and monitoring certain medication. However, TDM cannot compensate for errors in diagnosis, poor choice of drugs, errors in dispensing and dosages, errors in sample timing, non-compliance, etc. However, when used in combination with good clinical observation, it can lead to optimal drug therapy. So that's all about therapeutic drug monitoring. Thank you.